You are so warmly welcome to this Metal Education session. My name is Phil McElnay and I head up the team here at Metal. And if you haven't joined us before, we have some incredible education in store for you today. And you are so warmly welcome wherever you're joining from. We have got three incredible speakers joining us today on a really important topic. And today we're going to be talking about transforming menopause care in 2025. At the end of this event, we're going to be sharing a link with you as an email, which will allow you to give us some feedback. We'd really appreciate it if you can complete that. I'll pull up a QR code on the screen so that you can scan that and have it ready to complete if you need to do that. And we would really appreciate your feedback at the end of this session. We have some disclosures and it's really important that we share them with you, and I'm just showing those on the screen right now. Before we go any further, we want to tell you a little bit about what we're going to be covering today. And we've got three learning objectives that we hope we'll be able to cover in the time we've got together today. The first is this: to identify and manage vasomotor symptoms in menopausal women, including being able to apply an understanding of the role and underlying mechanisms such as the hypothalamic KNDy system. The second is counsel on cardiovascular health risks associated with a menopause transition. And the third is to implement comprehensive management approaches for sleep disturbances and mood changes. And we've got three amazing speakers who are going to help us do that. We have Professor Stephanie Faubion, who is a professor and chair at the Department of Medicine at Mayo Clinic Women's Health, and she's also the medical director at the Menopause Society. We've got Professor Hadine Joffe, who is the Paula A. Johnson Professor of Psychiatry in the field of women's health at Harvard Medical School. She's also the executive director of the Mary Horrigan Connors Center for Women's Health and Gender Biology at Brigham and Women's Hospital. And we've got Professor Jill Liss, who's an associate clinical professor in the Department of Obstetrics and Gynecology, and she's the director for OBGYN undergraduate medical education and the OBGYN clinical content director at the University of Colorado Denver School of Medicine. So we've got three incredible faculty with us today, and we're so grateful and honored to have them join us. Before we start on Metal, we like to ask you some questions. So we'd love to hear your thoughts before we dive into some education. We're going to ask you three questions just about how confident you are on these topics before we dive into some incredible education. And then we've got three poll or case scenarios to run through as well. And they're going to pop up on your screen if you're on Metal. If you're joining elsewhere, you can also join on Metal. You'll be able to answer these questions too. I'm going to bring the first one up now, which is this. Before we start this education, how confident are you in your ability to identify and manage vasomotor symptoms in menopausal women, including being able to apply an understanding of the role of underlying mechanisms such as the hypothalamic KNDy system? Rating from 1, not confident at all, right up to 5, very confident. If you can tell us in a poll, that would be great. I'll give you a few seconds to answer that. And the second poll is this. Before this education, how confident are you in your ability to counsel on cardiovascular risks associated with a menopause transition? 1, not confident at all, right up to 5, very confident. If you can give us your thoughts, that'd be super. Okay. And then the final confidence question is this. Before this education, how confident are you in implementing management approaches for sleep disturbances and mood changes? 1, not confident at all, right up to 5, very confident. If you're just joining us, we're doing some polls. We're really interested to understand where you're at the moment in your understanding in this area, and we'd really appreciate your thoughts. So you can scroll up in the chat and let us know your thoughts. And we're going to dive into 3 little cases now. And the first one is this 48-year-old perimenopausal woman presents for evaluation complaining primarily of significant sleep disturbance characterized by frequent awakenings during the night and some difficulty falling asleep. She has hot flashes several days per week, only occasionally at night, along with associated fatigue, but no depressive symptoms. Her sleep interruptions have worsened over the last 6 months, impacting her quality of life. She has no previous psychiatric history and denies suicidal ideation. She reports increased stress related to recent life events. And our question is this: considering evidence-based menopause management strategies for prominent sleep disturbances, what is the most appropriate initial treatment approach for this patient? Is it A, initiate hormone therapy, as it's highly effective for sleep disturbances, even in the absence of significant hot flashes? Is it B, recommend cognitive behavioral therapy for insomnia? Is it C, begin nightly benzodiazepines for immediate relief of sleep disturbances related to menopause symptoms? Or is it D, advise lifestyle modifications only, given the typically short duration of menopausal sleep disturbances? Quite a lot in there, so I'm going to give you a few seconds just to digest that and then let us know your thoughts. Thank you to those who have answered already. And you can just answer using the poll. And I'm going to start the second one, which is this, a little bit shorter. Which of the following statements is correct about fezolinetant or elezanitant? And your options are A, it is a serotonin norepinephrine reuptake inhibitor that reduces vasomotor symptoms. B, it competitively binds the estrogen receptor in the thermoregulatory center. C, it antagonizes neurokinin B receptors in the hypothalamus, reducing thermoregulatory overactivation. Or D, it requires long-term progestogen co-administration for endometrial protection. If you can let us know your thoughts. Okay, and then the final poll, and then we're going to start some incredible education, is this. A 50-year-old woman is concerned about her cardiovascular health now that she's entering menopause. She asks how her menopause itself might influence her cardiovascular risk. According to current evidence discussed in this session, you're going to learn hopefully what the answer is. How should you best counsel her? A, cardiovascular risk increases uniformly in women solely due to chronological aging, not specifically menopause. B, increased visceral adiposity, lipid abnormalities, and metabolic syndrome during menopause contribute to accelerated cardiovascular risk beyond normal aging. Or C, the timing of menopause does not impact cardiovascular risk if menopause occurs naturally after age 50. Or is it D, blood pressure elevation seen in menopause is definitively linked to menopause rather than chronological aging? And we're really grateful for you participating in these polls. And thank you to everyone who has answered. If you're joining on mobile, you might need to hit the little message button at the bottom, and then you should be able to see the chat and the polls pop up. Hopefully that helps those who are joining on mobile devices. Okay. Thank you so much. If you haven't had time to answer all of them, you can scroll up in the chat box and you can share your thoughts as to what you think the answers are. But it gives me great pleasure to dive into our session today and to introduce our first speaker, who is Dr. Jill Liss, who's going to be talking about hot takes on hot flashes, the physiology and novel treatments. Dr. Liss.
Thank you so much. I'm honored to be here today and honored to be speaking with my co-presenters on this topic. Today, I'll be talking about hot takes and hot flashes, the physiology and novel treatments. Here are my disclosures and our learning objectives today. So by the end of the talk, I hope that you'll be able to recognize and assess vasomotor symptoms, understand the physiology of vasomotor symptoms, including the KNDy neuron system, be familiar with evidence-based treatment strategies, and gain awareness about emerging treatments. Before we get started, I want to make sure I drive home a few points as the premise of this presentation. So first and foremost, women really need your help and expertise. Menopause care cannot be relegated to a small amount of menopause specialists. It's really on all of us who care for 51% of the population to have awareness and some comfort in prescribing and treatment of menopause symptoms. And also, very importantly, menopause is not just vasomotor symptoms. I will be talking a lot about them today because they are very important when it comes to overall impact on health and quality of life, and it's how we understand many of the available treatments. But please do not reduce menopause to only vasomotor symptoms. There are many other symptoms that are important to consider as well. And menopause hormone therapy does remain the first-line treatment for vasomotor symptoms and is safe and effective for most people. But there are novel and effective non-hormone therapies that are here and exciting to talk about. So I'm going to invite you to see a patient with me, Liss. She's scheduled for a menopause consult to discuss treatment options. Her symptoms started 9 years ago. She has very bothersome hot flashes that occur throughout the night and disrupt her sleep. She's soaking her clothes, changing them frequently. And 7 years ago, she did seek treatment and a doctor recommended black cohosh. She discontinued it shortly thereafter because of hives, and she's not currently taking anything to relieve her symptoms. She's just been dealing with them, but would like to explore natural treatment options. She's also having some cognitive fuzziness and particularly poor work performance on days she awakens with night sweats the night prior. You'll see in her history that she does have a history of hypertension as well as a mother with breast cancer, but she is desiring natural treatment. Elise's request maybe doesn't sound so unfamiliar to any of you. There's a fear of developing cancer and heart disease from hormone therapy, which drives many women to suffer silently from severe vasomotor symptoms and pursue natural non-hormone therapies that may be ineffective at best and very dangerous at worst. It's probably no surprise to any of you, but if it is, please know that many therapies are being marketed to women and being used by vulnerable people to treat symptoms ineffectively. So even earlier this week, a patient came to me with a supplement product of real beef organ superfood that contains 6 essential female-focused beef organs sourced from 100% grass-fed and pasture-raised cattle that promises more energy, balanced hormones, improved libido, improved mood, and optimal menstruation, all for $49 a month subscription. So it's really important to be understanding, to ask about what other things people have tried, because many of them can actually be dangerous and, of course, ineffective. So back to vasomotor symptoms. Again, these are more than just hot flashes. They are such an important menopause symptom because they're unique to menopause, and they affect up to 80% of perimenopausal menopausal women. The best estimative duration of vasomotor symptoms comes from the SWAN study, or the study of women across the nation, where we learned that the mean duration is 7.4 years, and 30% of women report vasomotor symptoms beyond 10 years and even 10% beyond age 70. So this is usually a 7.4-year process, but sometimes longer. And we are learning more about the evidence of the link between vasomotor symptoms and other parameters of health, particularly cardiovascular health, brain health, and bone health. And so we are starting to believe that in treating vasomotor symptoms, not only are we treating really bothersome symptoms that can significantly impact somebody's quality of life, but also potentially impacting other parameters of health, and improving cardiovascular health long-term, possibly. So hot flashes can be categorized as mild, moderate, or severe. Severe hot flashes lead to a sensation of heat with sweating, causing a cessation of activity, whereas a moderate one would lead to heat and sweating, but able to continue an activity, though it becomes bothersome. Hot flashes originate, the heat starts internally and spreads peripherally. It can lead to peripheral vasodilation and then ultimately sweating, and then the cooling effect that comes with sweating leading to chills or night sweats. All right, so pathophysiology of vasomotor symptoms comes from the thermoregulatory center in the hypothalamus. So there is an area of the hypothalamus called the median preoptic nucleus where KNDy neurons are acting as part of activation of thermoregulation. So typically before menopause, the KNDy neuron has a both inhibitory and excitatory receptor. The estrogen alpha receptor is inhibited by estrogen, so that will keep the neuron in a more quiescent state, whereas the neurokinin B receptor, or the NK3R receptor, is activated by neurokinin B. In menopause, when estrogen begins to decline, there is an excitatory, unchecked excitatory process happening for neurokinin B, and the inhibition phase that estrogen would typically be exerting on the neuron is much weaker. And so we have overactivation of these neurons impacting the thermoregulatory center, leading to increased vasomotor symptoms. It's important to get a good history in talking about vasomotor symptoms. There are many validated screening tools that you can use in your clinic, but you can also talk about with the patient, get a good history, talk about their symptoms. But in this slide, I just want to draw your attention to CAMA, which is a task force looking at core outcome sets as we study menopause. And they are developing 6 key outcomes for studying vasomotor symptoms, which include the frequency of vasomotor symptoms, the severity, distress and interference related to vasomotor symptoms, impact on sleep, satisfaction with treatment, and side effects of treatment. Again, this is mainly intended for research purposes, but as we talk about standardizing outcomes and vasomotor symptoms, would like you to be aware of the CAMA initiative and that they have identified the hot flash related daily interference scale, which is here, I know difficult to see, as a good measure of measuring distress, bothersome, and interference symptoms, as well as sleep. So when we think about vasomotor symptoms and treatment options, there are 2 general buckets of treatment, hormonal and non-hormonal. And non-hormone therapies include both pharmaceutical therapies as well as behavioral and lifestyle changes. And when I think about hormone therapy, this is really my holy grail document. And if you're not familiar with it, I highly encourage you to go get a free PDF of the NAMS or the Menopause Society position statement on hormone therapy. When we talk about hormone therapy, it's important to think about who's a good candidate and who is not. And contraindications to estrogen exist. So if somebody has unexplained genital bleeding, severe acute liver disease, an estrogen-sensitive cancer, coronary heart disease, MI, stroke, VTE, or a personal history of an inherited high-risk thromboembolic disease, probably not a good estrogen candidate. But there are some things that are not contraindications that are important to be aware of because many people get confused. So unlike OCPs, migraines with aura are not a contraindication, nor is well-controlled hypertension, smoking, diabetes, relatives with breast cancer, or even an inherited gene for breast cancer. I'm, again, not going to get too much into hormone therapy here today, but this is a slide that talks about the general types of hormone therapy, as there are several different buckets. And when we think about planning hormone therapy, it's important that we have a systematic approach that prioritizes use of FDA-approved hormone therapies, not compounded therapies. And it's also important to recognize that there are many, what many would call bioidentical FDA-approved hormone therapies. And you want to think about, you want to go oral or transdermal in your estrogen delivery. And of course, think about endometrial protection if the patient has a uterus, either with a progestogen or a SERM. As far as exciting novel things, there is a estrogen being developed in the pipeline, E4 or estetrol, which is exciting because there has not been a ton of innovation in hormone therapy for a long time. E4, there are 4 naturally occurring types of estrogens, and E4 is produced naturally in the fetal liver, but it is considered what's called a NEST, or a natural estrogen with selective action in tissues, because of the way that it differentially activates nuclear ER alpha receptors, but is antagonistic of the membrane ER alpha receptors. So the way this plays out clinically is that it has some unique actions on certain tissues and not others. And in the case of estetrol, it happens to fall along the lines of things we really like about estrogen while downplaying some of the more potentially negative impacts of estrogen. So it has a long half-life. It is activating or therapeutic on the genitourinary tissues, which is great for menopause. It's anti-resorptive in the bone, which is also good in this age group. Antagonistic at the breast, more so than estradiol, which is the predominant estrogen in hormone therapy, and has less induction of liver proteins, so possibly less thrombogenic than estradiol. So hopefully commercially available in the next year or so, and always good to have more options. And we'll move to non-hormone therapy. Again, there is a holy grail document from the Menopause Society on the non-hormone position statement that is incredibly helpful in navigating evidence-based non-hormone therapies. So here is a slide that highlights the interventions for treating vasomotor symptoms that are non-hormonal with good and consistent scientific evidence. Of note, I want to point out that some of these medications that are in the purple box are off-label use, but fezolinetant is on label for treatment of vasomotor symptoms. And here again is a slide from the Menopause Society outlining how to prescribe these non-hormone pharmacologic therapies. All but the paroxetine salt, the first one, are off-label. And these are the SSRIs and SNRI category of medications, showing about a 50 to 65% efficacy. And then here are the recommended more non-hormone therapies: gabapentin, oxybutynin, both of which are off-label, and fezolinetant, which is a on-label usage. All of these also tend to have a slightly higher efficacy. So back to our KNDy neurons and how fezolinetant, which is relatively new, moderates the KNDy neuron. So on this slide, you'll see these blue little dots binding the NK3R receptor are the fezolinetant drug. And so fezolinetant is selectively blocking or antagonizing the NK3R, and therefore downregulating the activation of the KNDy neuron, helping to restore thermoregulatory balance. Here, I know it's hard to see, but this is data from their Skylight trials that evaluated the efficacy and safety of fezolinetant in treating moderate to severe vasomotor symptoms. These were phase 3 randomized double-blind trials of 1,000 participants. And the primary endpoint was the change in vasomotor frequency from baseline to week 12. It significantly reduced vasomotor frequency across various intrinsic and extrinsic factors, with the 45 milligram dose, which is now what's commercially available, showing the biggest impact. And there was sustained effect over the 52 weeks. Again, hard to see this slide, but this is a systematic review and meta-analysis of change from baseline and daily frequency of moderate to severe vasomotor symptoms versus placebo of fezolinetant compared to other non-hormonal and hormonal methods. The grayed out ones are medications that are not available in the US. HT, you can sort of see over here, are hormonal therapies versus non-HT. Down here are the non-hormonal but recommended, though some off-label therapies. But what the takeaway to see here is that fezolinetant is a viable non-hormone therapy on par with hormonal therapies, and actually the only hormonal therapies that outperformed fezolinetant in this meta-analysis were therapies that are not commercially available in the US. And so a really nice option compared to hormone therapy for those who may not desire or are not candidates for hormone therapy. How to use fezolinetant. So it is, again, commercially available, and it is a little tricky to prescribe, but not so tricky. So hopefully this can give you a little bit of confidence in prescribing it. What's important is to check its interactions with other medications, particularly CYP3A2 inhibitors, which there are some sneaky common ones, and I recommend using an app like Accreditation, or if your electronic medical record has drug interaction checking. But some common drugs in this class are estrogen, valcyclovir, and Pepcid. Systemic estrogen is problematic, but not local vaginal estrogen, since that is not significantly systemically absorbed. And when you're prescribing, you want to check LFTs prior to initiation of the drug. And if either your LFTs or total bilirubin is greater than 2 times the upper limit of normal, not initiate fezolinetant. However, if you are less than 2 times upper limit of normal, it is okay to start. And then you'll want to check LFTs for all individuals at monthly for the first 3 months, and then at 6 and 9 months. If things remain normal through that duration, then you can stop checking LFTs. You don't need to continue forever. But when you are going along the way, if there is a greater than 5 times upper limit of normal elevation, that's when you need to discontinue meds, but can actually reinitiate if LFTs normalize. But if you remain under that threshold, then you can continue to monitor. I've seen certainly transient bumps using this medication, but nothing necessitating stopping the medication. And these instructions are available in the prescribing insert and readily accessible if you need to re-reference them. Switching gears, there is a new medication, elinzanetant, that is in the, I believe, the final stages of approval, and hopefully will be available within the next year, which is similar to fezolinetant in its action, but it also has a dual action on the NK1 receptor in addition to the NK3. Efficacy seems to be pretty similar, and the need for liver monitoring is not yet clear. It may not be required, as it's involved in a different metabolic pathway involving the CYP3A4. So you'll want to avoid those types of medications, some common ones being carbamazepine, phenytoin, and St. John's wort. So a little bit more about the NK1R receptor. This is NK1R is in the hypothalamus. So it's involved on the KNDy neuron in the thermoregulatory center, and again, is overexcited in menopause in the absence of estrogen, very similar to the NK3R pathway. But what is different about it is that it's also highly expressed in the brainstem regions involved in sleep regulation, particularly in the Joffe nuclei. And substance P activation of NK1 can increase wakefulness and reduce slow wave sleep, contributing to insomnia and fragmented sleep in menopausal women. So it's believed that the NK1R antagonism may improve sleep quality, which is why the dual NK1R, NK3R antagonists, or elinzanetant, are being investigated for both hot flashes and sleep disturbances. And this is data from their trial, OASIS 1 and 2, that assessed efficacy and safety of elinzanetant. And this is showing the frequency of moderate to severe VMS with reduction at 12 weeks compared to placebo. Similarly to the Skylight trials, the placebo group was offered active drug, and we saw improvement throughout the duration of the trial. And this is with the reduction in severity of hot flashes compared to placebo, again with crossover at 12 weeks. The NKR antagonists really do hold promise as an effective non-hormone treatment for vasomotor symptoms on a similar playing field to estrogen. And there are currently trials underway in breast cancer survivors, which I think is a really high needs case group for these medications. And we'll need some long-term post-marketing surveillance over time to determine long-term safety, but there appears to be, it generally appears to be well tolerated with long-term safety. And there's some other things in the pipeline. Innovation is always good. So in conclusion, these are a list of Liss's high-level scientific evidence options for treatment, including hormone therapy and non-hormone therapy. And ultimately, she does opt for cognitive behavioral therapy, but she's considering other options, and she'll be coming back to the clinic in 2 months to follow up. So that concludes my talk. I wanted to leave you with some resources. Here, this QR code is to a Google Drive where I've compiled really high-value guidelines like the position statements, as well as other salient papers and resources for yourself and potentially your patients. And then another passion of mine is medical education and education of training the next generation, so we have a more equipped workforce. And I developed a teaching module here. Please feel free to use it if you interact with learners and find it helpful. Here are my references, and thank you again so much for your time and attention, and I'd be happy to take any questions.
Thank you so much, Dr. Liss. What an incredible summary in a very short space of time. We're really grateful for you sharing that. We're going to have time for some questions at the end, and I can see that you have been busy asking us questions already, which is great. Please keep them coming. We'll have some time to cover questions at the end. Pop them into the chat boxes on whichever platform you're watching on or on Medal, and we'll pose them to our wonderful faculty at the end of the event. It gives me great pleasure to move on to our next speaker for today, who is Professor Stephanie Faubion, and she's going to be covering menopause and the heart, what clinicians need to know. Professor Faubion.
Thanks so much for having me today. It's my pleasure to be with you, and I'm excited to talk about menopause and the heart. I have no conflicts of interest. Our learning objectives today will be to counsel on cardiovascular health risks associated with the menopause transition, and specifically to discuss changes in cardiovascular risk across the menopause transition and explain a personalized risk reduction strategy. The menopause transition is really an opportunity for cardiovascular disease prevention. We know women develop heart disease a decade later than men, with a notable increase in midlife. The mean expectancy for a woman now is 81 years, and women will live about half of their adult lives in menopause. The menopause transition is a period of accelerated cardiovascular disease risk. We know that this transition is characterized by dynamic changes in estradiol and follicle-stimulating hormone levels. Not all women experience a uniform pattern of estradiol decline or follicle-stimulating hormone rise over the menopause transition, but we know about 44% of midlife women have a steep early decline almost 1 year before their final menstrual period. Approximately 6,000 women enter menopause in the United States every day. That's more than 2 million women every year just in the US alone. This is the stages of reproductive aging workshop, or the STRAW criteria. So I just want to point your attention to the words menopause transition and perimenopause in red so we can level set about what we're talking about here. So the menopause transition begins right after the late reproductive stage, and what it's characterized by is when menstrual length starts to vary by 7 days or more. So that means you could have a 21-day cycle 1 month and a 35-day cycle the next month. That means you've entered the menopause transition. The menopause transition ends when you have your final menstrual period. But here's the kicker. You don't know you're in menopause for a whole 12 months after that. So perimenopause includes the menopause transition and the first 12 months of no menstrual cycles. At that point, when that's over, you know you're postmenopause. What does the evidence show for cardiovascular risk factors and menopause? I frequently have patients coming in, they're complaining, they're saying they're gaining weight. I've never had issues with my blood pressure and my cholesterol. Now everything's going south. Is this related to menopause? So let's talk about menopause characteristics related to cardiovascular disease risk. This is the Framingham study. The relationship between menopause and cardiovascular disease incidence was examined in this Framingham cohort, which consisted of nearly 3,000 women. Cardiovascular disease incidence was defined as the occurrence of coronary heart disease, stroke, or congestive heart failure. You'll see here there was a trend for a 2 to 6-fold higher incidence of disease in postmenopausal women compared to premenopausal women in the same age range. These data demonstrate that there's also an age-associated increase in the incidence of cardiovascular disease for both premenopausal and postmenopausal women. In addition, these and other data indicate that the loss of estrogen in menopause is associated with an increased risk for heart disease above that seen for premenopausal women. This increase in cardiovascular disease risk is also seen in women who undergo a bilateral oophorectomy at a younger age. Note there was little to no association between bilateral salpingo oophorectomy and cardiovascular disease risk when the BSO occurred around the time of natural menopause, so that over 45 group. And importantly, you'll note that hysterectomy without BSO was not associated with increased cardiovascular disease risk, and that's noted in the dark navy bars here. Now switching to other signs and symptoms of menopause. It has been shown that vasomotor symptoms reported midlife are associated with adverse lipid profiles and greater incidence of hypertension. In this longitudinal cohort study of 3,300 women, this is a SWAN study, these were midlife women and they were followed up for over 20 years. The investigators found that frequent or persistent menopausal vasomotor symptoms, so hot flashes and night sweats, were associated with a 50% increased risk of future cardiovascular disease events. And these associations were not explained by standard cardiovascular risk factors or by endogenous estradiol levels. This is important because almost 80% of women experience vasomotor symptoms during the menopause transition. So again, increased vasomotor symptom frequency was associated with greater CVD risk and CVD mortality. So this showed that the same thing was found with persistent VMS. So frequent and persistent VMS were found to be associated with cardiovascular disease risk down the line. So what are the clinical implications here? We know that vasomotor symptoms may represent a novel female-specific cardiovascular disease risk factor. Midlife and older women with frequent or persistent vasomotor symptoms warrant particular attention for cardiovascular disease risk reduction and prevention. And it really does beg the question whether vasomotor symptoms are a manifestation of neurovascular dysfunction that we need to be aware of. Okay, so the summary here, we know an earlier age at natural menopause is associated with increased CVD risk. We know that bilateral salpingo-oophorectomy during the premenopausal period is associated with increased cardiovascular disease risk. We know that hysterectomy, regardless of ovarian status, is pretty neutral in terms of risk. And then vasomotor symptoms are linked with increased cardiovascular disease risk factors, CVD, and endothelial dysfunction. Let's talk about the cardiometabolic changes during menopause, and let's discuss whether it's ovarian aging, so menopause related, or is it chronological aging, just getting older. So body composition and fat distribution. We know that weight gain, pinching an inch, it's a very common complaint at the time of menopause. It's actually one of the most bothersome issues for women during this time, and this is what brings women in tears more than hot flashes, is this weight gain in menopause. However, we know that is more about aging than ovarian aging. So we know men and women gain weight in midlife. This is most likely due to reduced energy expenditure and a lower basal metabolic rate. However, we notice there's a shift from lean mass to fat mass. That's probably both ovarian aging as well as chronological aging. Whereas the bottom bullet, greater visceral adipose tissue in the abdomen, that is related to menopause. That fat gain, that persistent irritating fat gain in the midsection, that's a menopause phenomenon. Okay, this is the SWAN study, and it showed us that fat mass increases across the menopause transition, lean mass decreases. And if you look at that far right panel, the SWAN investigators looked at visceral adipose tissue longitudinally, and they identified 3 distinct trajectories. So the change in VAT, so VAT is visceral adipose tissue, was relatively modest for women who were more than 2 years before their last menstrual period. So that slope there is not that great. This was followed by a significant increase in VAT by 8% per year during the menopause transition. That's from 2 years before the final menstrual period to the final menstrual period. And then VAT continues to increase after that, but it slows down to about 5% per year after the final menstrual period. So we see an accelerated rate of visceral fat accumulation during the menopause transition. So this is related to ovarian aging. All right, these data show that increases in abdominal fat, VAT, in perimenopause are associated with log increases in carotid intima media thickness. So carotid disease. We don't see much of a change pre-menopause. We see this accelerated increase perimenopause, and postmenopause, it continues, but the curve is less steep. These models adjust for age, race, study site, smoking, LDL cholesterol, systolic blood pressure, and BMI. And we believe this shift is due to the loss of estrogen, which influences lipoprotein lipase activity. Lower estrogen is associated with decreased gluteofemoral lipoprotein lipase and increased abdominal lipoprotein lipase. So if you'll recall, lipoprotein lipase converts triglycerides into free fatty acids, which pass into adipocytes or fat cells. So this explains why the loss of estrogen is related to increased accumulation of abdominal fat. Estrogen is modulating really how fat is handled between perimenopause and postmenopause. So this is ovarian related. Let's talk about adverse changes in lipids. There are a number of adverse changes in cardiometabolic health during the menopause transition. For example, women experience adverse lipid and lipoprotein measures that have been linked to greater cardiovascular risk. Displayed here are the SWAN data, and as you can see, in addition to increases in total cholesterol, there are substantial increases in LDL-C and ApoB within the 1 year before and after the final menstrual period that are beyond what would be expected for aging alone. This increase in LDL around the final menstrual period is also related to plaque index in the carotid artery. And in this study, you can see that those who had LDL change in the highest tertile, so the far right, had the highest predicted probability of carotid artery plaque over an 8-year period around the final menstrual period. So again, increases in LDL-C, the change related to a greater probability of carotid disease. Changes in HDL function. This is kind of complicated. First, I'm going to define what cholesterol efflux capacity is so you can kind of level set with the slide. So cholesterol efflux capacity measures the ability of HDL to promote cholesterol efflux from macrophages. This is the first step in reverse cholesterol transport. We now think that greater CEC or improved HDL function rather than a higher HDL-C concentration is the mechanism of HDL's ASCVD risk reduction. So this is why HDL cholesterol is good. Oftentimes women enter menopause with very high levels of HDL, and so we do typically see a small drop in HDL, but this may be subtle. But HDL-C levels have a relationship with the menopause transition, and the quality or functional capacity of HDL has undergone alterations during this time frame. This is again the work from SWAN investigators, and it suggests that a key anti-atherogenic function of HDL particles, that ability to promote the first step in the reverse cholesterol transport, may weaken during the menopause transition. So what this means is having a lot of HDL post-menopause may not have the same protective effects that we would consider that molecule to have pre-menopause. So HDL doesn't seem to work as well post-menopause. All right, HDL-C before menopause linked with lower CIMT. So the menopause transition is associated with this reversal in the direction of association between HDL-C and cardiovascular disease risk, with higher HDL-C levels associated with less carotid atherosclerosis before menopause, but greater carotid atherosclerosis after menopause. So what I would like you to focus on here is the highest percentile of HDL change. That's in the black bars. You see high HDL less than 10 years before menopause, far left of this graph, associated with lower CIMT, whereas after menopause, look at the far right side, it's associated with increased CIMT, again suggesting that the HDL quality or function has decreased over the menopause transition, and that may be one of the reasons why we see increased CIMT over time. So thus, this change is related to ovarian aging versus chronological aging. The atherosclerosis risk in communities cohort documented that the progression and increase in the severity of the metabolic syndrome were greatest during the late premenopausal and perimenopausal years, rather than during the postmenopausal period. So you see this dramatic increase in the slope of the line, which is the increase in the percent of women with metabolic syndrome, really kind of goes upwards starting at about 2 years before the final menstrual period. This finding was more pronounced in Black rather than white women. And in summarizing, this appears to be related to ovarian aging rather than chronological aging. Let's talk about blood pressure. The association between blood pressure change and menopause is quite controversial. This one study you'll see was published in 1997, found that systolic blood pressure was 4 to 5 millimeters higher in postmenopausal women than it was in pre and perimenopausal women, as well as compared to controls, which were actually age-matched men. They were matched for age and for BMI. So these, again, you're not looking at that wrong. The controls were men. They found systolic blood pressure rose 5 millimeters per decade more in peri and postmenopausal women than it did in premenopausal women, which might be related to increases in the activation of the renin, angiotensin, aldosterone system as a result of the loss of estrogen. It's notable that studies have also shown that salt sensitivity increases in menopause, leading to an increase in blood pressure. Now, that's not the only study about blood pressure and menopause, and the SWAN study actually did not show the same finding. The SWAN study found that there were gender differences in blood pressure elevation over the life course, and that compared to men, women had a lower blood pressure in the earlier years, but a steeper rise in later years to where they surpassed men in terms of systolic blood pressure around the age of 60. So again, this is still debated whether this is ovarian aging or whether it's chronological aging. Let's talk a little bit about sleep apnea and menopause. Menopause is definitely a risk for sleep apnea for women. So about 3% of women have sleep apnea before menopause. This goes to about 11% after menopause. Probably several reasons for this. We know that women gain weight across the menopause transition, so they have more weight even in their neck area. The loss of estrogen supports the airway tissues, so the airway tissues actually get a little floppier after menopause. So these factors contribute to increased risk for sleep apnea. We know that sleep apnea is a risk for cardiovascular disease. So think about it in women, and women often have less typical signs and symptoms than men do. They might have an increased blood pressure. They might have morning headaches. They may report night sweats. And what we found in our menopause clinic is that these women tend to come in complaining of a lot of night sweats. And we found that about a quarter of the women in our menopause clinic were at intermediate to high risk for sleep apnea. And when they were later tested, a fairly high percentage of them actually had sleep apnea. So have a low threshold for checking women for sleep apnea. So let's talk about a summary of the cardiometabolic changes. We know that central visceral fat increases and lean muscle mass decreases are related to ovarian aging. But weight gain and reduced energy expenditure, that's across both men and women in midlife, so that's more chronological aging. Metabolic syndrome risk, that's more ovarian aging. Blood pressure we talked about is controversial. We're going to kind of put it in the middle for now. More data is needed. Decrease in HDL and HDL function, ovarian aging. Increases in lipids like LDL-C, ApoB, triglycerides, that's ovarian aging. Sleep apnea risk appears to be ovarian aging as well. So let's get to what we can do about this. The American Heart Association has recently come out and published Life's Essential 8. And I know you know all about this and probably counsel your patients on this on a regular basis, but it bears repeating. The Life's Essential 8 are the key measures for improving and maintaining cardiovascular health. So this is not magic stuff. Eat better. Aim for an overall healthy eating pattern. That's whole foods, lots of fruits and vegetables, lean proteins, nuts, seeds, cooking oils that are non-tropical, such as olive oil and canola oil. Be more active. The goal is that adults should get about 2.5 hours of moderate or 75 minutes of vigorous activity per week. Quit tobacco. Use of inhaled nicotine products, which includes traditional cigarettes, but also e-cigarettes and vaping. The leading cause of preventable death in the United States, including about 1/3 of all deaths from heart disease. Get enough sleep. Most adults need about 7 to 9 hours per night, and adequate sleep we know promotes healing, it reduces inflammation, it improves brain function. Manage all of your health factors, so control your weight. There's a lot of options available for that, including the GLPs. Control cholesterol, manage blood sugar and blood pressure. You're aiming for less than 120/80 on a regular basis. And I will say that there is plenty of evidence that your advice matters. So if you say something to a patient about needing to eat more fruits and vegetables or needing to stop smoking, they're actually listening to you. There are several ways to make your communications more effective. And bottom line is you kind of need to meet patients where they are. If someone has food insecurity, then telling them to eat lots of expensive fruits and vegetables may not be feasible. But in terms of helping patients with behavior change, employ your motivational interviewing skills. If a patient isn't ready to change now, ask what it would take for them to be ready. So there are factors influencing effectiveness. There are patient factors. There's your knowledge and confidence in providing this advice. And there's how and when this is delivered that matter. So the conclusions, let's talk about the key points. The menopause transition is an opportunity for cardiovascular disease prevention. It's a period of symptomatic, hormonal, physiological changes related to cardiovascular disease risk. Lipids, hot flashes, sleep apnea, metabolic syndrome, visceral adiposity are associated with ovarian aging and require an aggressive prevention-based approach for women during the menopause transition. But we know that weight gain, reduced energy expenditure, and blood pressure are more associated with the chronological aging process. Again, need to be addressed in just as an aggressive manner. And work with your patients to personalize a risk reduction strategy. And with that, I thank you for your attention.
Thank you so much, Professor Faubion, for another incredible session. We're really grateful, and we're going to have time for some questions at the end. So if you have some questions, and we've got some coming in, which is great, please keep them coming in the chat box or in the chat on the platforms that you're watching on, and we will pose them to our speakers at the end. It's a really great opportunity to hear from world-class faculty today. So keep those coming. Thank you so much, Professor Faubion. We are going to move on to our next speaker, who is Professor Hadine Joffe, and she's going to be telling us about the latest management approaches for sleep disturbances and mood change. Professor Joffe.
My pleasure today to be speaking with all of you about sleep and mood disturbance across menopause and approaches to treatment. For those who need to see this, here are my disclosures. I will be addressing any questions related to my disclosures along the way. So my task today is to talk about different ways to approach the nature of sleep disturbance, mood disturbance, and hot flashes or vasomotor symptoms and how interconnected they are. Also to review the risks and benefits of the current pharmacologic and behavioral interventions that address these core brain symptoms of menopause, and to evaluate the latest safety and efficacy data on non-hormonal interventions as well. I hope through all of this, it will help educate you and also help you to educate your patients on the importance and strategies for evaluating and treating these symptoms in midlife women. So as we all know, those of us who are treating these patients, people come in with these kinds of complaints. They feel that their brain is not working, and these are core symptoms of the menopause transition. The brain symptoms, people feel that they're not processing information, their attention is diminished, they're distressed, they're sleeping poorly, and of course, hot flashes are prominent. And these symptoms often present in very interrelated ways, so it's hard sometimes for people to disentangle which symptoms are bothering them. And it's also sometimes hard for us as clinicians to know how best to approach these treatments and how to disentangle them in terms of targeted therapies. So what exactly are these symptoms of menopause that I'm going to be focusing on? Here you can see these core brain symptoms, which are the hot flash symptoms, sleep, and mood disturbance. And along the way, I'll be characterizing that mood disturbance breaks down into depressive symptoms, which is a less severe and much more common condition, and also the more severe and less common condition of major depression. We know that hot flashes persist for much longer than we initially thought. When we've done studies looking across the duration of hot flashes across the menopause transition. Firstly, anchoring on the final menstrual period and 1 year afterwards being officially postmenopause, you can see that the median duration is between 7 and 9 years, and this occurs predominantly in the peri and in the post. So by the time women are 10 years from the final menstrual period, still a third of them will have hot flashes, and that's approaching age 60 on average. So these are prevalent and persistent symptoms for many women. We also know that hot flashes occur both day and night. This in the blue captures that we are able to detect biologically with skin conductance sweating detection, hot flashes occurring during these blue phases of the night as well as during the day. So they don't go away when people go to sleep. And we also know when we've done studies asking women who are seeking treatment for hot flashes, what are the other core symptoms that are bothering you that you're seeking help with? And sleep disturbance here is one of the most common secondary symptoms. It's very strongly linked with hot flashes. And of course, there are other symptoms that are bothersome, including brain cognition, fatigue, and mood. So just to back up and think a little bit about depression in general, not in midlife, the take-home message here is that women are twice the risk for major depression than men. And this has been seen in multiple studies in multiple countries. And this female predominance of major depression is something that occurs particularly across the female reproductive lifespan. That is, you start to see this bifurcation of risk in females over males around the age of puberty, and you also see continued risk across these reproductive years and through the menopause age. So when we see a woman who comes in midlife, I want to highlight the importance of thinking both cross-sectionally, what is she presenting with now, and also longitudinally, what does she bring with her in terms of her health history for these conditions of mood and sleep that we're evaluating. So of course we see her cross-sectionally. We see where she is in the menopause transition, what's the range of symptoms she has, what are the hormone profiles that we are either detecting or anticipating based on whether she's peri or post. So that's one way of thinking about it. We also are thinking about what's happening in her life now. What are the major stressors that are contributing to what she's presenting with? But that's cross-sectional. Then we want to think longitudinally. And for depression, as we think about the life trajectory for depression, it's important to realize that recurrence of depression, of major depression, is the norm for men and women. People have depression. Anyone who has one episode has a 50% chance of having a second episode. Anyone who has two episodes is over 90% likely to have a third episode. So the episodes occur, they resolve either spontaneously with time and distress or with treatment. And without continued treatment, they will recur. So by the time somebody approaches midlife, she's often had depression before. It's unlikely, although it does happen, it's unlikely for depression to occur for the first time in midlife. So you want to know what's her depression history? What are the treatments that have worked for her? What's the nature of her symptoms? Are they different? Are they the same as what she's experienced before? So we talked about at the beginning how there's major depression and depressive symptoms. And I just want to give you a little bit of a flavor about the difference of what we're talking about here. Firstly, there is over a doubling of risk of depression, major depression in the perimenopause. As I've said, it's almost always recurrence, and it can be linked with hot flashes and stressful events. This also risk connects with a history of anxiety, with medical illness, and importantly with sleep disruption. And we'll be talking a little bit more about that as the talk goes on. The other side of this is depressive symptoms, which is more common than major depression. It occurs in over a quarter of women during the perimenopause. And this is the condition that doesn't interfere with daytime function in the same way, doesn't lead to suicidal ideation. So by definition, it's a much milder condition. Who are the people who are likely to get this? You see the sort of clustering of both psychosocial risk factors and also hormonal or menopausal risk factors. And to highlight here the menopausal risk factors, that this includes the hot flashes, the sleep interruption from hot flashes, and the reproductive hormone dynamics. And I want to point you back to the slide on the text on the left, which shows that those hormonal factors don't drive major depression risk in the way they drive depressive symptoms. Now, we do know that the people who are susceptible to either major depression or depressive symptoms is a subgroup. It's not universal. And that's an important factor that I'll come back to in a moment. So how are these hot flash and sleep disruption symptoms interconnected with mood symptoms? Some of the research we've done has tried to really isolate these symptoms because, as you know, they come together in a constellation. And we do this experimentally by medically and temporarily inducing menopause in very controlled, highly regulated ways, looking at who develops hot flashes after a GnRH agonist, what's the change in polysomnographic sleep, and what's the change in mood. So this enables a kind of pre-post comparison for those who do and don't develop hot flashes, and these are non-depressed young women. So when we looked at predictors of depressive symptoms, we saw that sleep disturbance, of course, contributed to the risk of depressive symptoms. People who spent more time in light sleep of N1, people who had more sleep interruption and came into wakefulness more, and reported more sleep, worse sleep quality. We then looked at the hot flashes to try and understand, are they contributing to the mood disturbance? And we broke people down into these 3 buckets of hot flash occurrence. And when we did that, what we found importantly in the bottom here is that the nighttime hot flashes contributed to the emergence of sleep disturbance. So those who had frequent nighttime hot flashes had the most mood disturbance. And in contrast, there was no connection with daytime hot flashes. So the message here is that it's not because somebody's bothered or distressed or annoyed by having daytime hot flashes that she gets mood disturbance, is that she has nighttime hot flashes. And the hot flashes are separate from the sleep disturbance, meaning hot flashes themselves contribute independently of the sleep disturbance. So I want to go back to this question about subgroup, because we, together with a group of people led by Martha Hickey and Lydia Brown at University of Melbourne in Australia, published an analysis looking at the group of data, looking at risk factors for depression, major and subthreshold depressive symptoms. And the key take-home message here is that not everybody gets it. And of course, that's really important, but we wanted to highlight that because there's so much attention and fear about the mood disturbance in the midlife transition of menopause. And we wanted to try and put some boundaries on that to try and help guide people who's likely to be at risk. This study got a lot of press across a number of media outlets. And here's our sort of message, is that we wanted women to be empowered to understand, looking at their personal history, are they at risk? Not to have fear unnecessarily, to be prepared when they are at risk and to educate them. So this is something that, I think is a really important message, that we want people to be able to quantify their risks. And as clinicians, we want to help them understand if they are concerned, whether they're likely to be at risk, and to put fears aside where it's unnecessary fear. So briefly, I want to talk about, this association between hot flashes and sleep disturbance. Of course, hot flashes at night can be called night sweats as well. So what do we know about sleep? Sleep is not one unitary phenomenon. It's a very complex, multidimensional phenomenon. So when you start asking people about sleep, there are a lot of questions. How much time do you spend in bed? How many hours are you typically asleep, which includes, these wake after sleep onset, or also this interruption in the middle of the night. And then if you start looking at sleep patterns, how long does it take you to fall asleep? How many times are you awake? When you are awake, how long are you awake for? And so there are diary ways to do this. There's polysomnographic ways using EEG. There's actigraphy. There are multiple ways to do it. But as a clinician, you can ask all these questions, and you should. And I will highlight here that the issue with midlife hot flash associated sleep disturbance is a sleep maintenance problem. It's a sleep interruption problem. You do not see problems falling asleep from hot flashes. You do see problems with wakefulness in the middle of the night, which is called a fragmentation or an interruption. And here this captures it from some earlier studies, from our large cohort studies looking at waking up repeatedly. This is the condition from self-report that you see has become much more prevalent, up to about 40–50% as women are in the late perimenopause and postmenopause. Those are just to remind us that, you know, we can quantify this with EEG. I also want to highlight here that we are trying to superimpose the sleep interruption pattern on the hormone profile and trajectory across the menopause transition. And we've done studies showing that it is indeed, as the estrogen levels are low and unchanging, that is when you start to see the greater problem with the sleep interruption. And that is actually in contrast with what you see with mood. Mood disturbance is related to the estrogen going up and down like this and the lack of a progestin, whereas sleep disturbance is related to the low hypoestrogenic state. So it's not only midlife menopause that contributes to sleep disturbance. There are many other factors. You know, somebody may have depression that's occurring. There may be major life stressors. There's emergence of sleep apnea, and there can be a primary insomnia disorder that's often one that has occurred before or can be worse or new onset now. And these are interrelated. So as you're evaluating sleep disturbance, you know, trying to understand all these factors that may be contributed to their current sleep disturbance based on the nature of the sleep problems and also what their previous history is. So I mentioned that there's the hormonal profile, there's the depression contribution, there's a doubling of risk of sleep apnea, obstructive sleep apnea in women across the midlife transition. I'm going to now shift to the hormonal profile underlying the perimenopausal depressive symptoms, which I said is different than sleep. Sleep is where we see the stable low estrogen, and here I'll show you our data on both estradiol E2 and progesterone P4, which we measured in mildly depressed women not on treatment across 9 weeks, and we did this weekly associated with mood disturbance measures. So on the bottom left here, what you see is that the group in the this pink bar here, 30 to 40, their estradiol varied the most across this 8-week, 2-month period. And that was the group that had the worst sleep disturbance. So yes, indeed, their body, their brain was exposed to this variability, and that was triggering this mood disturbance. And that is one of the reasons why we believe that in the postmenopause, when the hormone, the estradiol variability is reduced and you see the stable flat level, that the mood disturbance risk seems to be diminished substantially. The other factor we looked at is progesterone. And of course, these are perimenopausal women who were ovulating intermittently. And we did see that having progesterone in the system, having an ovulatory cycle here, 1+, meant that the mood was better. So our interpretation of all this is that the mood is better when the ovarian activity is more normalized. So the converse is this perimenopausal profile of high fluctuations in estradiol and less progesterone because of diminished ovulation. That is a time when women are at greatest risk for depressive symptoms. So, you know, that occurs over time, right? And depression occurs over time. So if you're evaluating somebody, how do you know whether her hormone and menopause symptoms are contributing to her mood or not? So I want to point to some tips that I have from the way I approach this in my patient population. You know, the key question often is, what's the relevance of menopause to the mood state? The way I approach it is I draw the circle and I say, okay, based on the information you've told me, I think that the slice of this pie for you and your mood disturbance is small, large, etc., based on how likely I think that these hormonal or menopause factors contribute. So sometimes they're just coincident. You know, sometimes some major life event has occurred and menopause and midlife has nothing to do with it. And sometimes they're more causally linked. Sometimes there's a susceptibility. They are hormonally susceptible, postpartum depression, PMS, perimenstrual mood disturbance. So those are biological factors. The other thing, of course, always is to understand what people's outlook is on midlife and mood. And I'm struck by how powerful this is. It's not that this causes the mood disturbance. It's more that it is a time of life when there's a lot of reflection, a lot of identification with aging and evaluation of where somebody is in life. And so these things do contribute. And of course, you want to support people when those are problematic or very distressing. Menopause profile, we're going to look at where they are, peri or post, what their hot flashes are, what their psychiatric and antidepressant use history is, what their hormonal therapy risk profile is. And then the timing of their symptoms. You know, did the mood disturbance precede any sign of the perimenopause? Did it emerge immediately when their hot flashes and sleep disturbance occurred? Have they had a history of depression? I'm going to go very quickly through this slide because it is a lot of details and I don't want to get bogged down in the details, but I do want to say that there is evidence for depression being treated by hormone therapy, but I will explain the limitations of that. And there's also evidence of prevention, and I will also explain the limitations. So there've been a number of trials, most of them with transdermal, but some in the KEEP studies with oral progestins showing benefit. There's also evidence that when somebody's postmenopausal and doesn't have hot flashes, it's ineffective. So the best and strongest evidence is for estrogen for treatment of mild depressive symptoms in somebody with a lot of hot flashes. So you're targeting the hot flashes and you're getting the mood improvement as well. The estrogen is definitely not a primary treatment for major depression. If somebody has major depression, they should be treated with primary antidepressant strategy. The preventions, there's been one study looking at prevention showing some benefit in perimenopausal women in general. And the message here is that this would be very much off-label because we don't have data to support preventative approaches. And there's really no way to understand like who's the most likely candidate. So it's a risk-benefit analysis because you might be treating them for a long time and exposing them to treatment when they may need it later, and then they accumulate their exposure to hormone therapy over the years. So it's not a primary approach. What about antidepressants? The message here is that we've studied many, many antidepressants, essentially most of the serotonin-based strategies, and they are all effective. There's really no reason to think that one antidepressant is more effective than another. The non-serotonergic agents like bupropion have not been studied. We don't typically decide that an SSRI or an SNRI should be used, but we just use them, and we use them in combination with hormone therapy. There are other novel treatments for severe depression, which I won't get into here. I will say that we are looking at allopregnanolone precursors, which relates to the progesterone pathway as a strategy for perimenopause. So we talked about treatments of major depression here, pharmacotherapies, antidepressants, more interventional approaches, possibly allopregnanolone, and that hormone therapy is not first line, but could be used if there's very prominent hot flashes that are being treated. Psychotherapy, of course. Whereas in contrast here, the subthreshold symptoms, similarly, the serotonergic agents, that is a time when hormone therapy has shown much more benefit, and this does include oral conjugated equine estrogens with the cyclic progesterone and other agents being studied. Let's shift now to sleep interruption to make sure we understand what are the behavioral strategies and then what are the pharmacologic strategies. So there's this notion of sleep hygiene that, like dental hygiene, you sort of approach in a maintenance way how to have optimal sleep. And many of us know these things about avoiding coffee and so forth. I want to highlight some key messages for menopause or hot flash associated sleep interruption, because that's the middle of the night problem with sleep, and that we don't typically think about as much in terms of sleep hygiene. But here are some key strategies that somebody should be using themselves, which is do not look at the clock when you're awake in the middle of the night. As soon as you look at the clock, as soon as you have any visual stimulus, you're really much more alert. It's much harder to go to sleep. You start ruminating, preoccupying. So you should not know what time it is in the middle of the night. If you're tossing and turning in the middle of the night and can't get back to sleep, you should get out of bed. You should try to get yourself back to sleep for a few minutes. You don't know exactly how many minutes, but then you should get out of bed, low light, reading, no digital exposure, and then get back into bed. There's also a very powerful treatment called cognitive behavioral therapy for insomnia, CBTI, which has multiple domains of behavioral strategy that are both cognitive, also behavioral. And this we've shown to be highly effective for treatment of this sleep interruption in menopause with hot flashes. So a number of us had a large multi-center network called MS Flash, where we looked at a range of interventions to treat hot flashes in almost 1,000 women in multiple trials. And this figure on the left here shows the sub-analysis we did with the sleep disturbance or based on the insomnia severity index. So the higher the line, the greater the benefit. We're treating hot flashes. We did not select on sleep disturbance, but we looked to see what benefit these women got for sleep disturbance. And what you can see here is the cognitive behavioral therapy for insomnia was the most effective. You can also see that exercise was effective. It actually didn't treat the hot flashes, but it did treat the sleep disturbance. Yoga was effective. Then moving on to medications, in the orange and in the purple, the serotonin agents were effective. And here in the blue, estrogen, estradiol, which we use a low dose oral agent, was less effective. And in general, when there have been studies looking at estrogens in relation to other treatments for sleep disturbance, it is typically less effective for the sleep disturbance associated with hot flashes. So just thinking about pharmacologic approaches, one strategy which we use here is target the hot flashes. We think that's contributing to the sleep disturbance, so let's target them directly. And, in general, when you do target hot flashes, you do see improvements in sleep. These are the strategies that have been studied, including the serotonergic agents, gabapentin. I'll show you the neurokinin agents in a moment. Hormonal agents, we talked about estrogens, typically with the progestins themselves have been studied, although very limited evidence, and the T-sex, the combination of estrogens with SERMs, beneficial for sleep. Just to think about the other strategy to treat the sleep disturbance, which is not necessarily to target hot flashes, but to say, okay, we have a sleep problem. It might be a condition called insomnia or a milder sleep interruption. What are the strategies to use? We have studied the non-benzo GABA agents. Those are the quote-unquote Z drugs, like zolpidem, cautious with the dose, but those have been studied and we've shown them to be effective. Just to highlight here that we've also studied orexin antagonists, which are FDA, EMA approved to treat insomnia. And in a menopause population, we showed benefit in this insomnia symptoms over placebo. So to sum this up, to say in terms of treatment, how do we think about the treatments? Hormonal, non-hormonal, which are mostly psychotropic, the novel compounds like neurokinin antagonists, and then behavioral strategies, thinking both really across all of these dimensions of these brain symptoms of menopause. This is a summary of what I presented. There's nothing new here, but to highlight that, hormonal therapy improves the mild depressive symptoms when hot flashes. Some evidence for depression, but definitely not first line. Traditional antidepressants, all effective. We really don't have data on major depression for the novel agents, and there's behavioral and other therapies are effective. The VMS, I'm not going to go into here because that's not the focus of my talk, and you'll be hearing about that. But just to highlight that when we're talking about sleep disturbance in those with hot flashes, you get modest benefit from hormonal therapy. With regard to the psychotropics, you do have benefit from the Z drugs and also the orexin antagonists. And as I mentioned, the neurokinin B agents, particularly the Xanatat, has shown benefit. And CBTI, hugely, hugely effective. So let me wrap this up with the summary slide here to say that, this is a complex time with a lot of symptoms that can be very disruptive to people's well-being and function. And this includes mood disturbance, which can present as a major depression or a mild subthreshold depressive symptom. This is probably the most important evaluation to determine, is this a serious condition? Is there suicidal ideation? Is somebody functioning very poorly or not? That helps you strategize about approaches. The mild symptoms are much more common, associated with this hormonal profile and the nighttime hot flashes, as well as the sleep interruption. Unfortunately, major depression is less common and typically represents a recurrence of depression. Hormonal therapy is beneficial for the mild symptoms and when there's prominent hot flashes. So that's the subgroup to use them in. And I highlight this because we do not want to leave people on hormone therapy expecting benefit and then not fully capture symptom control for a significant depressive condition. Antidepressants, they're good. They're very effective in this population, and we should be using them as well and encouraging them as well as behavioral strategies and psychotherapy. And the last point about the sleep disturbance is that there are different ways to treat it. One way is to target the hot flashes when the condition of sleep disturbance is sleep interruption related to hot flashes, noting here that hormonal therapy may be less effective. And the other approach is to directly treat the sleep disturbance without expecting necessarily a hot flash control. And that may be a beneficial approach. So I'll pause there, and I'm happy to take questions, and I appreciate all of your interest in this material.
Oh, Joffe, thank you so much for another incredible piece of education today. We have covered a lot of ground in a short space of time, so I'm so grateful. We have got some incredible questions coming through from our audience. You have been really busy, and we've got a very short space of time to cover questions, but we'll try to get through as many as we can. So I'm going to dive right in, and perhaps I can start with you, Dr. Liss. You provided a really comprehensive overview of the KNDy system, its role in vasomotor symptoms. Given the complexity of that system, what are the key clinical implications for managing vasomotor symptoms, and how do you translate that understanding into practical treatment decisions?
Yeah, I think really just overly simplistically, of course, thinking about the yin and the yang, or the activation and the inhibition, where when estrogen is missing, this is a tool to create that inhibition on the neuron and restore thermoregulatory balance. That would be my easiest way to present it. Maybe even I would try to be even more simplistic with the patient, but really thinking about a way to quiet down the neuron when estrogen is not available.
Great. Prof. Faubion, we've got some really interesting questions about cardiovascular health risks. We've had quite a lot of comments on estradiol. We've got a really interesting question about adipose tissue. So you mentioned the significant impact of visceral adipose tissue accumulation on cardiovascular risk. Beyond lifestyle modifications, which we've had some comments on in the chat, what are your thoughts on the role of emerging therapies like GLP-1 receptor agonists in mitigating that risk during menopause transition?
That's a great question. I think the GLP-1s have a lot of promise for a lot of different aspects of what's happening to women during this time, not only weight reduction, but there is some evidence that they're good for cardiovascular and renal health as well. And stay tuned, but we are now studying them for hot flash management too. So I think we'll learn a lot more about the GLPs in the coming years, but I think they're definitely it's a possibility, and the concern about the longer term use is going to be the loss of muscle mass along with fat mass too. And so I think we're going to have to be careful with that because we really don't have a lot of long-term data in these folks yet. So great question.
Perhaps sticking with you, Prof. Faubion, we've got some really great comments about estradiol. You highlighted the increased cardiovascular risk associated with menopause transition. And given the variability in estradiol decline, how do you recommend we personalize risk assessment and tailor preventative strategies for individual patients, especially those with pre-existing cardiovascular risk factors?
Yeah, thank you for that question. I wish we were down to that precision medicine about understanding how quickly estradiol declines and what that means for cardiovascular risk. We're just not quite there yet. So I think we're still looking at each individual woman and her cardiovascular risk factors as she goes through this menopause transition. So really it's looking at blood pressure, et cetera. I see another question on how do you differentiate blood pressure changes related to aging or menopause? Well, given that we don't know exactly whether blood pressure changes are related to aging or menopause, that's challenging. But some women become more salt sensitive through the menopause transition, and the renin-angiotensin system is more activated. So I think I would focus on limiting salt intake and maybe an ACE inhibitor in that way. So I think there are some things that you can do and that women may respond to more, but it's still going to be individualized based on the woman. Great question.
Yeah, we've got some really great conversation going here, and perhaps I'm going to move on to you, Professor Joffe. You emphasize the interconnectedness of sleep disturbances, mood changes, and vasomotor symptoms in patients presenting with that system or that symptom cluster. How do you prioritize treatment strategies, and what are your thoughts on concurrent use of hormonal and non-hormonal therapies?
Yeah, that is really the challenge. Firstly, the first part of your question, which is, people present, they often can't discriminate the symptoms. They feel sort of just overwhelmed. So I think it's helpful to say, these seem to be the core problems you're having. Ask them, which one are you most bothered by? Sometimes people's when their mood is really low, they're bothered by other things, but they aren't always aware that the issue is their mood. So, of course, as a clinician, we have to assess that and say, I think your mood, you really seem different than you were, and your mood seems to be a major factor, but you need to partner with them to see which symptom to target first. Sometimes to say, we could use this approach or this second approach, and that would target your primary concern or what you perceive and agree on is the primary concern. If you can use one approach, medication, that's of course better than two. Behavioral strategies, as I said, are fantastic for a variety of problems. However, sometimes, you need more than one medication, and so it's appropriate to use them, whether it's hormones and an antidepressant or other combinations. I think the other thing is, starting two medicines at once, may not be the best strategy. Sometimes you want to start with one and then see them pretty rapidly afterwards. Say, we've given this the right amount of time to determine whether it's likely to benefit, or we should move on to another one, add another one. And so, of all of take-home messages for that is don't leave them on one medicine for a long time and not see them back. Like, see them back when they're having a lot of these symptoms altogether.
And perhaps staying on that same theme, with the new neurokinin receptor antagonists showing promise for both vasomotor symptoms and sleep disturbance, how do you see these agents fitting into the overall management strategy for menopausal women over the next 5 to 10 years? And what are your considerations for long-term use?
Yeah. So right now in the US, one of them is available, fezolinetant, and that's the only one that we have available. We may have another one available as a linitant in later this year. We don't know. If both of them are available, then we have tools for that. There's stronger data with azilinitant for treatment of sleep than there is with fezolinetant. So that would be one, decision point between the two if they're both available. Right now, we don't have data on mood disturbance for either one. We certainly know that there's quality of life benefit. So for women with vasomotor symptoms, of course, they would be options. And if there's a sleep component that's meaningful and significant with the vasomotor symptoms, then eventually, if azilinitant is available, that would be a good option.
And we have run out of time, but we're rapidly running out of time. But we'll have one last question, which I'm going to pose to you, Dr. Liss, which is this. You mentioned the importance of addressing patient fears and misconceptions about hormone therapy. What are your most effective communication strategies for counseling patients on the risks and benefits of both hormonal and non-hormonal treatments? Good question.
It's a great question and a really hard one to rapidly end with. But, I think paramount is to truly understand what the concern is and where it comes from. I find with active questioning and listening that it's individualized what that concern may be. And I try not to assume what one person's fear or concern is the same for another. So I would say it's individually tailored. And then I try to really just talk through the data in a digestible format, talking about other relative risks that one takes in daily life, that Viagra has risks of blindness that are greater than most of the risks of hormone therapy, whatever might land for a certain person. I think risk is such a hard thing for most people to really understand and digest. So whatever bits of culturally or temporally relevant things we can draw on is very helpful in temporizing.
Thank you so much. We do not have any more time. We've had lots of really great education, lots of really great questions, and I'm so grateful for our wonderful faculty this evening. Just a massive thank you from us for your time, for sharing your experience, your pearls, for answering so many questions in such a short space of time. We are so grateful, and I can see from the comments in the audience that they are too. So just a massive thank you from us. I hope if you're in the audience this evening, you find that useful as well. Professor Faubion, Professor Liss, Professor Joffe, thank you so much for your time.
Thank you, everyone.
So much.
Thank you.
So that just leaves us to share the final thing, which is how do I claim my CME certificate for joining today, which I'll bring a quick QR code up on the screen for you if you are joining us on Medall, and it will also be visible on the other platforms as well. You can just scan that QR code, complete the short evaluation, and you'll be able to claim your free CME certificate for joining us. And we really appreciate the feedback. We are constantly trying to improve, do things better, keep making education radically accessible for colleagues everywhere. And your thoughts, your feedback really help us to do that. So we're really grateful for that feedback. And I hope that you find this event really helpful and useful. It's certainly been a pleasure to host you, and we hope to see you at another Medall event sometime soon. Thank you so much. Have a really great rest of your day.